All right, thank you, Dr. Hernan, for that introduction, and certainly I hope my check is in the mail as well. I'm truly excited about our next speaker and her presentation. When helping put together the SFU portion of the spring meeting, I decided a discussion on prune belly syndrome would be a great topic. We all have a handful of patients with prune belly that we provide lifelong care for them, and certainly the care that we provide these patients is multifaceted. But when looking at the literature regarding the care of these patients, it is highly variable and may vary from just being conservative and watchful observation to being as aggressive as full genital urinary reconstruction and abdominal wall reconstruction. Thus, I thought an update on the modern management of prune belly syndrome would be appropriate for this meeting. When deciding who should give such a talk, it took me about 30 seconds to decide on Dr. Baker. She certainly requires no introduction, as we all are well aware of her basic science and clinical expertise regarding the management of children with prune belly syndrome. I would like to thank Dr. Baker for her willingness to participate in our virtual event, and I know we all look forward to hearing her presentation. And so with that, I give you Dr. Baker and the modern management of prune belly syndrome.
Good morning. I'm Dr. Linda Baker, a professor of urology at the University of Texas Southwestern and a pediatric urologist at Children's Health in Dallas, Texas. It is my great honor and pleasure to speak today on the modern management of and an update on prune belly syndrome. For disclosures, this work is financially supported in part by an NIH R01 grant I received, the UT Southwestern C Endowment, an AUA Research Scholars Award to Dr. Nitha Iqbal, an NIH T32 training grant to Dr. Stephen Harrison, both in my laboratory, a UT Southwestern Service Package grant, and Prune Belly Syndrome Network, a 501c3 nonprofit organization for families and children with prune belly syndrome. In this lecture, I'd like to discuss what is prune belly syndrome, what causes prune belly syndrome medical management and surgical management, and future directions for study. So what is prune belly syndrome? So we all know that the prune belly syndrome triad consists of 1. Absent or hypoplastic abdominal wall musculature, 2. Urinary tract distension from dysfunctional smooth muscle, and 3. Intra-abdominal testes. However, it's much more than a triad, as over 60% have extra genitourinary manifestations as well. About 1 in 40,000 births are affected by prune belly syndrome, of which 95% are males. The statistics are rather sobering, as there is a significant and unknown number undergoing pregnancy termination, 20% are stillborn, 30% die of renal failure by age 2 years, and in a lifetime, 67% will have renal failure. Thus, this leaves about 1,500 cases in the United States under the age of 18 years. Fortunately, the vast majority of these children have normal cognition, but overall, their life prognosis depends on the severity of lung and renal dysfunction. And one of the first to recognize this was Dr. John Woodard, one of our forefathers in pediatric urology, who made major contributions to our knowledge on prune belly syndrome. In 1978, he published a classification system which scored prune belly syndrome children into one of 3 categories based on their phenotypic severity. Specifically, this classification system centered on the degree of renal and lung dysfunction. Patients in Category 1 will likely die in the neonatal period, leaving survivors to be classified into either Category 2 or 3. However, I would argue that children surviving after the neonatal period with prune belly syndrome consist of a much broader phenotypic spectrum than what can be shown in 2 categories. Over the last 10 years, I've had the great pleasure and fortune to collaborate with the Prune Belly Syndrome Network. Through their annual conventions, I've been able to socialize with and perform research studies with over 170 children and adults with prune belly syndrome, firsthand showing me this broad phenotypic spectrum. So let's look back at the triad again. The spectrum of abdominal wall laxity and muscular deficiency is broad. Some may be only mildly affected. Others have extreme abdominal wall laxity, which permits the displacement of the intra-abdominal organs into what is in essence a massive ventral abdominal wall hernia, disrupting abdominal function of Valsalva and causing cosmetic disfigurement. Similarly, the urinary tract is a spectrum of anomalies. The kidneys may range from being normal to having minimal to severe hydronephrosis with or without dysplastic renal parenchyma. Vesicoureteral reflux is present in 75%. These refluxing ureters have a characteristic distal greater than proximal hydroureter with poor ureteral peristalsis due to dysplastic ureteral smooth muscle. The megacystis of Prune belly syndrome can yield bladder capacity 2 to 8 times normal with a thick-walled, highly compliant, poorly contractile detrusor giving elevated post-void residuals. Most have a dilated bladder neck and dysplastic prostate, but more variable are a patent urachus, megalourethra, and/or urethral atresia. While the normal bladder detrusor has fascicles of smooth muscle with intervening bands of connective tissue, the Prune belly syndrome detrusor has lost all organization of fascicles, and on electron microscopy, the smooth muscle cells are separated from each other by a thick sea of collagen. While all Prune belly syndrome testes are intra-abdominal, there still is a spectrum of findings. This left intra-abdominal testis has relatively normal anatomy with a recognizable gubernaculum, internal ring, inferior epigastric vessels, testis, epididymis, and vas deferens. In contrast, this right intra-abdominal testis is associated with a wispy gubernaculum and absent internal ring. A closer look reveals an atypical testicular vascular supply and significant segmental malformation of the epididymis and vas deferens. These findings may necessitate creative means to achieve a successful orchiopexy, whether it be done laparoscopically or through an open approach. And concerning the extragenitourinary manifestations, in 2015, we reviewed the extragenitourinary manifestations in 65 children with Prune belly syndrome at mean age 10 years and found that over 60% had gastrointestinal and orthopedic malformations, while 40 to 50% had cardiopulmonary anomalies and neurological deficits. With this information, I felt it time to take a fresh, comprehensive look at Prune belly syndrome. To push the field forward, I felt we needed a new way to categorize Prune belly syndrome. So we created a practical, quantitative, organ system-based phenotyping tool for granular Prune belly syndrome phenotype severity scoring. The new scoring system would be used to group similar cases, to identify the cause of Prune belly syndrome, to perform genotype-phenotype correlative studies, and to permit subgrouping of Prune belly syndrome phenotypes for outcome analyses, thereby sorting the apples and the oranges. Last year, we published our new PBS phenotype severity scoring system and applied it to 50 patients. Here we see the rubric for the RU-based scoring system. The term RU-base is an acronym derived from the 6 subscored categories. RUBAC stands for renal, ureter, bladder, abdominal wall, and cryptorchidism. Each of these categories have their own maximum score that can be achieved. E stands for extragenitourinary, which can be scored based on the organ system or by congenital genetic syndromes or associations. The score from each of the 6 subcategories is summed to yield the RU-based score, which can range from 5 to 31. Using the RU-based scoring system on 50 PBS cases, we noted 3 categories of PBS. 39 cases had isolated Prune belly syndrome. In the remaining cases, however, the children had either Prune belly syndrome plus, where other unusual conditions were present, including hepatoblastoma, hearing loss, infantile stroke with optic nerve atrophy, early gout with type 2 diabetes and pancreatic atrophy, or mydriasis. Others had a PBS with known syndromic or genetic conditions such as Duchenne muscular dystrophy, Pierre-Robin sequence, Voxterol, or MMIHS. By plotting the rebase score on the x-axis and the number of PBS cases on the y-axis, we see that most of the 50 test cases were in the mild to moderate PBS severity category. But by studying the more severe cases of Prune belly syndrome, the hope is that maybe we can figure out what causes PBS. Historically, there have been two major theories for the embryonic maldevelopment of PBS. In the first theory, a severe bladder outlet obstruction occurs early in gestation, causing dilation of the bladder, ureters, and abdominal wall with secondary oligohydramnios and pulmonary hypoplasia. The problems with this hypothesis are that it does not explain all extragenital urinary PBS manifestations, and bladder outlet obstruction is documented in only 15% of infant autopsy cases of PBS. In the second theory, a primary embryonic mesodermal arrest occurs due to altered gene regulation of myogenesis. Maldevelopment of the somatic and splanchnic mesoderm results in dysplastic or absent muscle of the abdominal wall, urinary tract, and gubernaculum. Dilation of these organs occurs without anatomical obstruction. The problem with this hypothesis is that the key regulatory drivers of myogenesis and the details of the genetic dysregulation was previously unknown. However, now there is new information. There are known environmental or epigenetic causes for Prune belly syndrome. However, over 13 publications have reported multiplex families with 2 or more affected individuals with Prune belly syndrome. As well, there are cases of concordant twins who both have Prune belly syndrome, and most patients are males. These all point toward a genetic basis of Prune belly syndrome. Nevertheless, rare disease research is challenging, especially when the disease leads to diminished survival and diminished reproductive fitness. And thanks to the Prune belly syndrome network, as well as many pediatric urologists listening to this lecture, my research team has thus far recruited 174 PBS-affected individuals, as well as hundreds of their unaffected family members for genetic studies. Despite having this sample size, more PBS cases are desperately needed for this genetic research, and I gladly welcome your help in this regard. Here are shown categories from 5 multiplex families that have participated in our research. Black squares indicate live-born PBS-affected males, and black diamonds are PBS pregnancy terminations. White slashes indicate postnatal deaths. We initially focused on the D019 family at the upper left. This mother had 2 spontaneous miscarriages, as well as the 2 shown living children with Prune belly syndrome, fathered by 2 different fathers. This strongly suggested X linkage. Using whole exome sequencing, the laboratory found the causal gene. In addition to Prune belly syndrome, these young males both had facial anomalies, micrometia, and bilateral cleft palate, as well as clinotactile with hypoplastic distal phalanges and toe anomalies called free frog feet. Their mother was more mildly affected with facial dysmorphism. Expanding the pedigree out further showed additional individuals with these facial features, 2 additional infant deaths with Prune belly syndrome, and several spontaneous miscarriages, all based on the maternal side of the family. Whole exome sequencing of the mother and her 2 sons identified novel sense point mutation in the filamentary gene located on chromosome X28. This filamentary DNA mutation alters the filament protein at amino acid 160 and cysteine to arginine. This field of 1 chromosome, the 2 sons are hemizygotes for this mutation. The mother is a heterozygous carrier with X inactivation mutant. Thus, this family has syndromic Prune belly syndrome, both Prune belly syndrome and the otopalatodigital spectrum disorder. After finding a mutation in this affected syndromic PBS disorder, after After finding a Filament A mutation in this severely affected pedigree with syndromic PBS, we then screened our other familial and non-familial prune belly syndrome cases. We found 2 other males with novel Filament A mutations more mildly affected by prune belly syndrome, as shown by their lower Roubaix score. While they were not from a multiplex family and did not show otopalatodigital spectrum disorder, in both cases their mother was a carrier of their unique mutation. Thus, these 2 cases have isolated prune belly syndrome since they lack additional dysmorphic features. We published this work earlier this year in BMC Medical Genetics. So to begin to understand what is Filament A and how does it cause prune belly syndrome, we first must take a step back and remember our basic urology. We remember that the bladder is innervated by the pelvic nerve, carrying parasympathetic neurons that release acetylcholine. Acetylcholine stimulates the muscarinic 3 cholinergic receptor on detrusor smooth muscle cells, causing smooth muscle cell contraction. The bladder is also innervated by the hypogastric nerve, carrying sympathetic neurons that release norepinephrine. Norepinephrine stimulates the beta-3 adrenal receptors that cause detrusor smooth muscle cells to relax. The pudendal nerve innervates the external urethral sphincter. Pudendal neurons release acetylcholine, stimulating the nicotinic 2 cholinergic receptor. This mediates external urethral sphincter skeletal muscle contraction. Now let's deep dive and look at a relaxed bladder smooth muscle cell. In the cytosol, we see the actin and myosin filaments that make the motor units which contract and generate force. On the cell membrane are the muscarinic and beta receptors. Spanning the cell membrane is the focal adhesion complex. It is a group of regulatory proteins that bind actin on the inside of the cell and bind extracellular matrix on the outside of the cell. When a smooth muscle cell contracts, a series of events occur. Quickly, a ring of actin fibers polymerize just underneath the cell membrane to stiffen it. As the cytosolic actin and myosin motor units slide and contract, they pull on the focal adhesion complexes and the extracellular matrix, thereby causing the cell to stiffen and become smaller, transducing force from the inside to the outside of the cell. Filament A, which we found mutated in some cases of prune belly syndrome, is a critical regulatory protein in the focal adhesion complex. While one end of filament A binds actin, the other end can bind or release integrins. Our prune belly syndrome mutations cause filament A to be stuck, bound to integrin, which at the molecular level makes the cell unable to contract and feel chronically stretched. In addition to filament A, in the last 5 to 10 years, there have been 13 additional genes found to cause megacystis. These genes include smooth muscle transcription factors such as myocardin, which is a smooth and skeletal muscle differentiation factor that turns on the smooth muscle specific actins and myosins during embryogenesis. DNA mutations in this gene work in an autosomal dominant fashion, with heterozygous males having congenital megabladder and homozygous males and females having megabladder with cardiovascular anomalies. Megacystis can also be caused by mutations in smooth muscle cell contractile filament protein or enzyme genes. For example, heterozygous mutations in smooth muscle alpha-actin causes multisystemic smooth muscle dysfunction syndrome with mydriasis in an autosomal dominant fashion. Whereas heterozygous mutations in smooth muscle gamma-actin causes MMIHS, chronic intestinal pseudoobstruction, and visceral myopathy. Megacystis can also be caused by mutations in genes for cytoskeletal regulatory proteins like filament A, and for genes in neuroenzymes or receptors, such as mutations in HPSC2 and LRIG2, which cause Ochoa syndrome, or homozygous mutations in CHRM3 and CHRN2, which are the genes for the muscarinic and nicotinic acetylcholine receptors. These mutations can cause megacystis with mydriasis in an autosomal recessive fashion. Now we can definitively conclude that many PBS cases are caused by human mutations in known genes that regulate embryonic myogenesis. Now let's talk a bit about the medical management of prune belly syndrome. In general, how can we medically make life better for individuals with PBS? And then more specifically, how can we, as pediatric urologists, medically optimize prune belly syndrome infants prior to surgical intervention? Because the major problem that we're faced with early in life is that flaccid abdominal wall. It affects their pulmonary function because the loss of Valsalva push leads to poor cough and expectoration. It affects the GI and the GU tracts, again, by having loss of that Valsalva, decreases their ability to push with defecation and with voiding, respectively. And also it affects orthopedic function because the loss of trunk posture and balance causes strains on the hips and the spine and alters gait and exercise tolerance. Thus, caring for prune belly syndrome requires a large multidisciplinary team approach to help these children thrive and gain weight. Since we are experts in prune belly syndrome, we often must lead the team and make referrals. Now let's talk specifically about some of these crucial team members that we might not typically speak on. I think physical therapists are critical for the care of prune belly syndrome. As we all know, physical therapists use treatment techniques to promote the ability to move, reduce pain, restore function, and prevent disability. As ECI is a state program for developmental disorders, which is for children up to age 3 years, physical therapy should be financially covered if you refer. Because during infancy, gross motor skills develop, and pediatric physical therapists use these standardized quantitative gross motor development tests to measure the child's gross motor skills development at all ages of childhood. And specifically, the two most commonly used tests are the Peabody Developmental Motor Scales Test, or PDMS-2, for children under the age of 4 years, and the BOT-2 test of motor proficiency, which is used for children over the age of 4 years. These are both standardized, age-adjusted, and are internationally used. So I was able to get 4 physical therapists interested in studying prune belly syndrome and specifically asking the question, how is gross motor development in children with prune belly syndrome? And we also were curious whether it might answer who needs abdominoplasty and who has benefited from abdominoplasty. So we started by doing a cross-sectional study and enrolled 29 children with prune belly syndrome for gross motor milestone and proficiency testing using both the Peabody and the BOT-2 tests. Because these two gross motor tests have a breakpoint at 4 years, we divided our 29 patients into those under and those over age 4. Group A had 12 patients that averaged 1.9 years old. None had undergone abdominoplasty. On the PDMS-2 test for gross motor skills, they scored extremely low at 17th percentile. The Group B patients who were over the age of 4 years consisted of 17 patients. We broke this group of 17 into 2 groups, namely 3 patients without abdominoplasty and 14 patients status post-abdominoplasty. There was no difference in the mean age of these 2 subgroups at around 10 to 11 years of age. BOT-2 gross motor testing found their mean percentiles to be extremely poor, at 5.7 and 18.6 compared to age-matched normal controls. However, there was no statistical difference between those with and without abdominoplasty. Thus, we can conclude that nearly all prune belly syndrome children, infants to teenagers, have significantly delayed gross motor development with or without abdominoplasty, and the PDMS-2 and BOT-2 are useful tests to evaluate the severity of gross motor dysfunction in prune belly syndrome. So what can physical therapists do about this significant gross motor developmental delay? Physical therapists can fit prune belly syndrome children for trunk compressive garments that can improve Valsalva and gross and fine motor development. For the older child, a TLSO spinal brace, shoe inserts, aquatic therapy, general muscle strengthening, and postural re-education can be greatly beneficial. For children like him, as well as other weak prune belly syndrome infants, an assertive pediatric pulmonologist is critical to prevent recurrent pneumonia, hospitalizations, and weight loss. This care needs to be not just medication-based because weak abdominal muscles are accessory muscles of expiration. We know that weak abdominal muscle contraction yields an ineffective cough mechanism. So we studied, does an abdominal binder improve Valsalva? We measured the maximal inspiratory pressure and the maximal expiratory pressure with and without an abdominal binder tightened by 5% of the abdominal circumference. We did this in 22 patients with a mean age of 16.2 years, and 54% of them had had a prior abdominoplasty. Now, an abnormal percent predicted value for maximal inspiratory or maximal expiratory pressure is less than 80%. We found that Prune-Belly syndrome patients have weak muscles of respiration with maximal expiratory pressure more severely affected. We also found that the abdominal binder tightened by 5% of the abdominal circumference did not significantly improve the percent predicted MIP or MEP, but 75% of these children after abdominoplasty remained with very large abdominal circumference, greater than the 80th percentile for gender and age. So, what can be done about a low maximum expiratory pressure and weak cough? A take-home message is to push the pulmonologist for a vibratory chest wall oscillation system such as the vest to help your PBS patients clear their trapped secretions. It can be life-saving. Now let's talk about the surgical management of Prune-Belly syndrome. Let's look at the last 50 years of surgical history for Prune-Belly syndrome. Here we see some of the basic component procedures that have been used for Prune-Belly syndrome, including vesicostomy, partial cystectomy, internal urethrotomy, which has basically fallen out of favor, the Padua procedure, which has variable results, laparoscopic orchiopexy, and appendicovesicostomy for Prune-Belly syndrome. And here we see the time course of when Randolph, basic component procedures that have been used for Prune-Belly syndrome, including vesicostomy, partial cystectomy, internal urethrotomy, which has basically fallen out of favor, the Padua procedure, which has variable results, laparoscopic orchiopexy, and appendicovesicostomy for Prune-Belly syndrome. And here we see the time course of when Randolph, Ehrlich, Montfort, Dennis, and Smith added to our knowledge by describing their methods of abdominoplasty. And here's the surgical history reporting outcomes on total or comprehensive open reconstruction for Prune-Belly syndrome. This involves upper urinary tract reconstruction, lower urinary tract reconstruction, abdominoplasty, open orchiopexy, and circumcision all at one setting. This was first described by Woodard and Parrott in 1978 when performed under the age of 6 months, and in 1989 by Fowlett, in 2015 by Lopez and Dennis, being performed on older children around the age of 1 year. So how do we synthesize this all together? In order to maximize spermatogenic potential, we need to try to achieve bilateral scrotal testes by the first birthday. Because vesicoureteral reflux is unlikely to resolve, the bladder capacity will likely continue to massively expand, the abdominal wall infrequently improves, the testes do not spontaneously descend, and because a child is at high risk for UTIs, a comprehensive open reconstruction is desired, again, by their first birthday. And in 2015, Dr. Dennis and colleagues described eloquently their experience with 46 Prune-Belly syndrome patients with the comprehensive open reconstructive technique. They showed 90% stabilization of the upper urinary tracts, 81% continence and voiding with lower urinary tract reconstruction, 90% improved abdominal wall tone and appearance with abdominoplasty, an 85% success rate with open orchiopexy, and a diminution of UTIs with circumcision from 89% down to 39%. But with the positive, there is always some negative. Dr. Dennis found 36.9% of patients had complications, including things like ureteral obstruction, vesicular reflux, cryptorchidism, acute admin, bladder failure, persistent abdominal wall flaccidity, and end-stage renal disease. But things don't always go as planned, and these children are complex. Things that can delay the surgical management of Prune belly syndrome children include imperforate anus requiring diverting colostomy, urinary diversion surgeries because of recurrent UTIs and urosepsis, recurrent pneumonias, CKD, and renal failure requiring peritoneal dialysis line placement, failure to thrive requiring G-button placement, and the need for open hip dysplasia reduction surgery. These all can delay comprehensive open reconstruction. Now, there are other controversies, especially within abdominoplasty. Do we need to add muscle? Some of our plastic surgery colleagues have championed the functional dynamic abdominoplasty. In this, the rectus femoris muscle is transposed from the leg by detaching it distally and rotating it up onto the abdominal wall. 2 publications show that it has been used in 12 children and adults with Prune belly syndrome. Here we see the extent of coverage of these rectus femoris muscle flaps. And here are the resulting leg scars about 8 years after surgery. So in conclusion, I hope that this lecture has stimulated further questions for you, such as, can we create more rigorous means to measure pre-op disease status and post-op outcomes? Which PBS children need abdominoplasty, and what is the best type of abdominoplasty? Who needs laparoscopic orchiopexy? Can we minimize the need for CSC, APVs, and abdominal wall reoperations? And how does the genetic mutation affect surgery? I'd like to thank the many who have contributed to this work, including PhD students, technicians, research coordinators, pediatric urology fellows, collaborators, and pediatric urologists, all in the U.S. I hope you all have had as much fun along the way as I have. This talk is dedicated to Emma Sanchez, who tirelessly and passionately worked with me to help children with Prune belly syndrome. Her work defined the word dedication. And as one last reminder, please help by enrolling your PBS patients in this research. Thank you.
All right, well, great. Thank you so much, Dr. Baker, for that talk. Let's see. Well, now we're going to take some questions from the audience here. Let's see. First question: is there a role for reduction cystoplasty in patients with severe megacystis?
I think that's a very controversial question. It seemed to be more championed several years ago, and I don't see so much writing about it. But I think that in the very extremely enlarged bladder, that it can have a role, especially if there's, a component of a urachus at the top where you might have some stasis up inside of that as well. So I wouldn't say I would absolutely insist on it or rule it out. I think it's a case-by-case decision.
Okay. Let's see. I mean, it seems like you advocate for treating these kids almost, very similar to how we treat our spina bifida children, where they're seen by a number of different specialists, and and need to be seen by need that multidisciplinary care. When the child is born with Prune belly syndrome, are there certain referrals that you believe that they should have? And you mentioned physical therapy, but should all of them be evaluated by a pulmonologist or evaluated by a cardiologist?
I think they probably all should be. Most of the neonatologists are really good at assessing for especially pulmonary or cardiac, but I think that it's also true that once they get out of the realm of neonatology, that for some of the children that kind of teeter on the border of needing it or not needing it, some of them will just kind of fall off the railroad tracks, and then they don't have a champion for pushing for ongoing pulmonary care, especially. I think the cardiac pretty well gets figured out pretty quickly, but the pulmonary, I find, is the one that impacts us the most. I think most of us are taught that if you're going to go and have surgery on a Prune belly syndrome child, that you should probably schedule them for an ICU bed post-operatively because their chances of having problems after surgery is so great. But I think that from the day-to-day management, like us, pulmonologists might not have a big experience with Prader-Willi syndrome children either. And so I think that if there is a take-home message, it would be to really push the pulmonologist to not only use medications, because I remember I had a child who had 7 pulmonary meds, and I'm like, okay, shouldn't we be doing something else? And as soon as we got the child the vest, that vibratory percussive device, it really made a huge difference, as well as did just doing the abdominoplasty. So the child went from having 7 meds to no meds at all after his abdominoplasty. So I think pulmonary is an under-recognized thing. And we kind of, I think, depend on our pediatricians to push for that referral, but I think that we should be equally strong in advocating for it.
Sure. Let's see, another question here. Prune-Belly syndrome, just like any other thing we take care of, is a spectrum. Other than orchidopexy, some patients may do functionally fine. Is there a way that you determine, what patients actually need what done?
Yeah, I think that's kind of one of the biggest questions that we all are faced with is, I think it's obvious who needs an orchiopexy. And I think that when you have high grade reflux, and especially with UTIs, you may have to consider diversions and or reimplantation. But it's that abdominoplasty, I think, is the big kicker as to really who does and who doesn't need it. And so I think that if I could advocate for multi-center studies, that would be a great question to answer, would be to try to, one, quantify really how severe is the abdominal wall dysfunction. And then 2, try to answer your question is who does and who doesn't need it.
Okay. And in those patients who you feel need an abdominoplasty, at what age are you performing the abdominoplasty?
I too agree with Dr. Dennis. I think that it really should be done quite early. And again, it's part of it is driven by the desire to get the testes into the scrotum. I think that although some have written that Prune-Belly syndrome uniformly causes infertility in adulthood, I have found going to the Prune-Belly syndrome networks that is not the case. Of course, you don't always have paternity testing to truly document it, but I think that there's evidence, at least I have a family where I showed that the child had the same mutation as inherited from his father, and those were natural conception children. So I think that it's not fair for us to assume that these kids will be infertile. And so I think we should try to push for orchiopexies as we would any other cryptorchid child. And then therefore that oftentimes will drive when you do the abdominoplasty. So, because that can all be combined. Dr. Parrott and Dr. Woodard, they really pushed for trying to do the combined surgical approach before the age of 6 months. And, that might even have some merit to it. I think that their complication rates were much higher in that age group. But I think that, the practical matters that are at bay are that these kids are so medically and complex that some of the times other things that, they slow your desire to get them to surgery. So you have to kind of squelch all the really raging fires first before you can go and do what we want to do.
Sure. And if you're not performing an abdominoplasty and you're moving forward with just doing the orchidopexy, how do you approach those children?
I trained with Dr. Steve Dosimo, who is a big advocate of laparoscopic orchiopexy. And so I think that is fantastic means to do it. And it allows you the ability to consider clipping the vessels too. Many people have said that it's unlikely to actually need to clip the vessels. I personally haven't found that to be the case, but none of us have a very massive experience with Prune-Belly syndrome. So that I think that's one of the challenges of our field. I think that the other thing to consider about the testes is that, just in general, in every single part of their body. Their blood vessels are weird in these kids with Prader-Willi syndrome. And I think it's really true for the testicular vessels and any collaterals. And, the vas isn't always, and the epidermis that are not always continuous. And that's true for the vessels there too. So I think that you really almost have to look as best as you can at the vessel arcades that you have to deal with and kind of decide what you think is the best thing to do. So how's that for a nice ambiguous answer?
I think that works for an ambiguous subject, right? Well, it looks like that'll be our last question. Again, Dr. Baker, I'd really like to thank you for putting together this fantastic talk and for all your flexibility in doing this virtually. And with that, I will hand the program back over to Dr. Herndon.
Thank you all.
Thanks, Doug.
Bye.